just a brief note about Professor. So Professor Karol Sikora is a world-renowned oncologist and advocate for improved universal cancer treatment. He was a clinical director of cancer medicine at Imperial College Healthcare. In 2015, he founded Proton Partners International, introducing the UK's first precision proton beam therapy in 2018. He also founded Cancer Partners UK, Britain's largest independent network of cancer treatment centres, now part of Genesis Care. A former chief of the WHO Cancer Programme, he also established Cancer Partners International to build affordable cancer centres in developing countries. He is a fellow at Corpus Christi College in Cambridge and the founding dean of Buckingham University Medical School. Professor Sikora has published over 400 papers and 20 books, including the leading British cancer textbook, Treatment of Cancer. Please welcome Professor Karol.
I really wish I hadn't accepted this invitation, Helena. First of all, the title, The Future of Healthcare. What am I going to say to this audience? And secondly, two powerful blonde ladies before me. Fantastic! How can I win here? I can't. And I'm keeping you from your dinner. Let's pretend the year is 2050. Let's pretend we go to bed tonight, instead of an hour difference, it's 25 years difference nearly. What's healthcare going to look like? Whether it's the NHS in Britain, the NFZ in Poland, it doesn't matter. It's all going to be the same. Different countries will have different ways of approaching the problem, but the problems will be there. So to make it simple, I'm divided into 4 boxes for the future. The first box we've actually just heard about, 2 fantastic talks about precision medicine. Not just by looking at different clinical features, examining people with stethoscopes, but by very sophisticated precision tools, genomics, genetics, behavioral studies. And so the technology box is the first box we have to open in 2050. And what do we see there? It's more of the same, of course. We can extrapolate what we've heard here, but what we can't see so easily are step changes. So futurologists can't predict the step changes because when they come, people make a lot of money out of them, obviously. They set up companies, biotech companies, diagnostic companies, and they develop them. So the 2 step changes, I remember vividly where I was when I saw them as step changes. The first was 1975. I was a registrar in oncology in Cambridge, and I saw my first CT scan. Godfrey Helmsfield had invented it in the late 60s in Wimbledon at the Atkinson Morley Hospital, now part of St George's. And amazingly, you could see the detailed anatomy of a cancer for the first time. It was like going to the dissecting room as a medical student. You could see it. That was a step change. No one could predict that what it would lead to. It's led to CT, MRI, PET CT, all these other things have come because of that discovery. The second thing that I saw was in 1988. I remember hearing about the PCR reaction. Now my 11-year-old granddaughter knows what a PCR is because of COVID, of course. But then we didn't know about it. We didn't know what the implications of PCR and all the related technologies that come with it would bring to diagnostics, for infection, for shock, for all sorts of other things, and for cancer, of course. So the future of technology is totally unpredictable and will go faster than we ever think because of the drive for innovation that leads to change. And we can't see that. We can see, the sort of genomic programs we've seen here for blood pressure, fantastic. But maybe something's going to come that's going to make it so simple. And I think the other thing about technology is becoming more obvious that it's being marketed direct to the consumer. You go on the Underground at Westminster Station and you'll see a big poster for Randox, for diagnostic blood tests. Simple blood tests, the sort of things, FBC, LFTs, all that sort of stuff. You can see that there. That probably is the future. Direct to patients and then explaining to the patients what it is. And the NHS, for all its faults, is moving towards that sort of service. We now do get blood test results on your mobile phone. And that's only in the last 3 or 4 years that that's actually happened. So Technology is changing, it's going to get better, things are going to improve. So the technology box is fantastic. The second box is society, and that is very difficult to analyse where that's going, because of course healthcare is part of society. The one surety is that people are getting older and they're going to get frailer. And my colleague Susanna, who sat on my right, runs a frailty programme in West Yorkshire, and we heard about frailty from Agnieszka earlier. Frailty is very important in society because it means people can't live independently. Someone has to look after them. Now, care homes have come. In the old days it was a granny annex, but now care homes are there. Society is changing. That has profound implications. It changes differently in different countries. So in Asia, for example, in rural Asia, families are still together, they look after their elderly, and it's a tight bond of the family that's responsible. In Western societies, that bond is gone. The granny annexes have gone, care homes are there, and the problem for the future is when people get frail and ill in a care home, where do they go? The only place is the emergency room, and that clogs up the acute beds in the healthcare service. And it doesn't matter whether it's in Krakow or in London, it's the same problem. And there's no way around it. It has other implications. We know now that more than half of the people in this audience are women. Your doctors, your women. That wouldn't have been the case when I was a medical student. It was 10% of the year were women, maybe even less in some medical schools. So things have changed. Women work. They can't suddenly stop to look after elderly relatives. So that's another problem we've got. We've got to discover something in 2050 when you wake up tomorrow morning that allows for elderly, frail people to be looked after in some sort of intermediate facility that's halfway a hospital and halfway a care home. And that's the only solution. You know, everyone's got excited about assisted dying in the last few weeks. You know, I suspect it will be used so rarely that I think less than 500 people a year will actually want assisted dying. So that's the society box. So technology is there, society is coming, and of course technology can be applied to older people, to frailty, and you can see that all the time. Wearables that predict certain things, predicting when someone is going to suddenly become ill. And the healthcare trajectory is going to be a series of downward things, gradually going down with some acute drops, and then going back a bit and so on down. And the health economic implications of that are huge. The third box is how we deliver care. At the moment, you look across the river, the beautiful view over there, St. Thomas's Hospital, big hospital. It's from the days that that's not how medicine is going to be in the future. We don't need, the illnesses of the future are not going to be cured by going into a big glass building with a big atrium, but all hospitals have big atriums, and coming out after a day or two completely cured. You know, the orthopedic surgeons amongst you might like to think that's how medicine is done, but I can assure you it's not done like that. Medicine of the future is a series of different illnesses and comorbidities in older, frailer people. And the hospital has less importance as a structure than society to look after those people. So the future will all be about daycare, whether it's cardiology, whether it's cancer, it's all about daycare. And the centres we built in the UK, now run by Genesis, were all daycare centres. Some in retail parks, some in business parks and so on. You don't need the infrastructure of the hospital. So how we deliver care will be local, it will be direct to the customer will be very much involved, just like the adverts on the tube. That is going to be the future of that. And the fourth box is the most difficult box of it all. How are we going to pay for it? Who is going to pay? There's only three ways realistically you can pay for health. Number one is tax, number two is insurance, and number three is cash. And there's every other idea, charity, sure, the hospice, palliative care, a British invention, fantastic, was paid for by charity. But it's not sustainable to imagine charitable care all the time. It can be used to pump prime projects, such as frailty again, but it can't be sustainable. So you have to choose which of those three you're going to do. And every country, again, Poland, UK, uses a mix. Both Poland and UK on the whole, tax-based systems. The Polish, a very interesting model of the NFZ, And of course it changes with time. What's it going to look like in 25 years' time? It is very unpredictable. Private sector has handles on getting investment. There's no doubt that the private sector can attract investment because the investors want their money back. So that's the downside of that. The good side, the money's there. The money's there tomorrow if you want it. The public sector, as you can read in the papers all the time, I'm sure tomorrow it'll be in the Sunday papers, it'll all be about the next week's budget. It's all doom and gloom, where there's no money left in it. You imagine money. So I think the future of how we come to pay for healthcare is absolutely vital. And health economics has never been more important. I tell all the young doctors that I work with that the most important specialty is not oncology, not cardiology, not even psychogeriatrics. It's money, it's health economics, because we do have to learn how to balance the books in how we deliver healthcare. And once I was asked, how would you improve things quickly, Karol? So I said, well, I'd take everybody that's over 70 into the car park and shoot them from the hospital. That would clear the whole backlogs everywhere. And now I'm over 70 myself. It's moved up a little bit. But seriously, we do have to rethink how we deal with healthcare. So the 4 boxes of the future, the technologies are short, and that's going to go great guns. Society is going to change again, and it's going to change in different cultures. The delivery of care will change. There will be providers in unusual locales, and of course, the COVID pandemic sped up virtual consultations in a way that nothing else could have done. I mean, that's just transformed oncology follow-up, I can tell you. I used to see these old chaps with a prostate clinic at Hammersmith, and unless there was a medical student there, I'd never examine them. There's no point examining. You've got scans, you've got markers. Why would you examine someone if they've got no problems? So that's changed that. And then I think the biggest problem is how we pay for care and how we deal with life years, basically, lost life years. Do we treat a 90-year-old to the same aggressive level as a 40-year-old, for example? And that's a question that only society can answer. So the futures are short. It's going to be great waking up in 2050. I suspect, because you're a very young audience, average age about 35, I think, looking around. I left my spectacles at home, I think. You'll be about 70 then, and it's going to be a challenge, there's no doubt. But I think optimism that we will find ways to be more precise in how we tailor our therapy, whether it's blood pressure pills, whether it's cancer treatment, or even whether it's predicting decline in older people due to multiple factors. Thank you very much.
Fascinating talk, and as I said, that book as the token of appreciation. Thank you very much. I'm sure there will be more questions for Professor Sikora, so if you could stay here, I'll put it aside for you if you don't mind. Are there any questions in the audience? Sylvia.
So a question from the audience, but hopefully in the room, having spoken at the 75th about Flaherty. What's really interesting, I think, is what you're saying, and I remember saying 5 years ago we were going to have hospital at home, we were going to be able to deliver IV antibiotics, subcut fluids to our elderly frail population in homes, and that's happening within 5 years. I run a virtual ward currently, and certainly AI is becoming the new thing, and the ability to almost do point of care testing in people's own homes so they can stay at home. But my question actually is about how do we cope with the Gen Z generation? So I have a daughter who's currently studying medicine in Edinburgh, and I can see the total difference in the way she's taught medicine and even in her attitude. And what we've got is a set of junior doctors that are perhaps different in their way of thinking. And how do we get that sort of future for us, which still enables us to remain the profession we are, but actually have those really sensible conversations with our 90-year-olds, with our 80-year-olds, so that we keep driving forward and don't always look at age.
There's no real answer, Susanna, to that question. I think that the problem we have is that societal change is so gradual, you don't see it coming. You know, the PCR and the CT came suddenly and they were there, the technology change is there. But the societal change is very subtle, and as you say, Gen Z doctors behave differently from how I behaved when I was young. Not only that, to get into medical school now, you have to have the highest grades possible. It's ridiculous. There are people with 4 A's at A level, with 4A stars, that don't get into medical school. And yet, you know, in my day, we could get in with minimal grade A levels. And so that's, okay, there's been grade shifts in the exams and so on, but it doesn't explain it all. If you select from a very powerful intellectual group, you may not get the factors you want to look for, which is empathy, quality of understanding of people. And that is so difficult to assess, just like your quality scores are very difficult to assess. So I think the future, one thing I haven't mentioned that may help a bit is robotics and what you could do with robotics, including AI speech. You know, companies are using it now to deal with calls and so on. We're a bit averse, my generation are totally averse to doing that, but you know, it might just work. It might just be that you can have a much, just like we use GPS, and I can assure you, the lady on the GPS is much more polite than my wife when she used to try and navigate on a map. So I think the future is, imagine all the technologies coming together.
That was a great talk, Karol. So my questions were again around the societal. I think in the last year or two, particularly in Western societies, lifespan is actually decreasing for the first time. So I just wonder your thoughts on that, and in relation to that increase in mental illness, drug addiction, you know, particularly in Scotland, I think there's very high rates of drug use. You know, what's the point of all this increasing tech, increasing understanding of genomics, if that the crux of the matter or the soul of society is actually decaying?
It's a very good question, Peter. And again, there really is no answer to that. You know, all one can do is try and use the same technology to predict where mental health is going to be affected. And you know, I've got a few friends that are psychiatrists, I'm willing to admit it, and there's no doubt their attitude is quite different and quite bizarre, especially the younger ones. I don't quite know what that means for society later on, but they're dealing with extremely complex, unmeasurables. Whereas in oncology, on the whole, you have tumor markers, you have scans, you can assess what's going. Is it getting better, worse, or staying the same? That's what you ask every patient that comes to follow up. In psychiatry, it's very different, and the mental health of society is determined by the physical health of the customers in the society, but also external features. So at the moment, a lot of anxiety about what's happening in Britain. You're walking out there, you can see the anxiety, the police everywhere out there. And that wasn't there 2 years ago. So how it all goes in the future is very unpredictable. So not a good answer, but that's all I can come up with.
Any more questions for the audience?
Sorry, a very quick one. Going on from what Piotr was saying, one thing you didn't mention was preventative. And I think that's such an important thing from a paediatrician, again, seeing these children, and you can see the natural history of obesity, of hypertension, of renal disease, of psychological, psychiatric, and the life expectancy going down, and we can actually see it in predictive models. Can you expand on that?
No, prevention is important, and that's sort of in the technology box, I would say, that there will be ways of doing it from measuring the sort of the blood pressure prediction that someone's going to develop. It goes even further from what we've seen, I'm sure, and I'm sure Anna would agree with that. But and I think for everything, prevention will be, if you knew you were going to get something, rather like the blood pressure, if you knew your genes were bad, you would take those statins, or your antihypertensive medication. So it adds to it, it's this tailoring. I always think, you know, colorectal screening, the stuff that comes through when you're 60, you get the thing in the post, and you know, the compliance is relatively low for a screening test. But if you knew you had a high risk for some reason, before you did it, you do it every year, and you'd welcome the thing coming in the post, and you submit to a colonoscopy and so on. So precision tailoring the prevention to individual people at highest risk makes sense, and it would increase the compliance. So I think that's the way that will go.
Tailoring it to society, maybe, because the problem is much broader, and if you try and talk to a teenager, this is good for you, what sort of response? You might get a response 5 years later, and the damage is done.
I think it's also like watching the smokers on the street. Who's smoking out there? Young people, girls, still smoking. It makes no sense.
And you'll still have people that, for example, know they've got a risk of a disease or may have a genetic disorder but do not want to know. And they are sometimes the worst people because, you know, unfortunately, that becomes then an anxiety and they don't necessarily and they don't necessarily take preventative steps, which is really sad.
Are there any more questions from the audience?
I'm a big enthusiast of oncology, hematological cancer in my case. The big frustration is access to clinical trials, and unfortunately, Britain lags behind countries like Germany and Netherlands. What could we do in the future to make things better?
The problem is not in the treatment, it's not the quality of care once you've got to the front of the queue. The problem is the delay in diagnosis. So if you look at the league tables, we are below even parts of Eastern Europe now, the old Eastern Bloc. And the reason for that is so slow, and it's multifactorial: patient stoicism, GP access, access to scanning, access to biopsies. It's that diagnostic pathway. So the 5-year survival is poor. The 1-year survival is even poorer in Britain, and that suggests as the diagnostic part. That's the best evidence for that. And obviously anecdotal evidence, if you look at surveys of how quickly cancer patients get to start treatment. The official target is 62 days from diagnosis to treatment, from presentation to GP to first definitive treatment. And that is not being met in around nearly 50% of trusts around the country. So that's where we need to do something. And you know, that costs money, and it costs a change in attitude of how we pass people through the system. And because you don't know who's got cancer and who's not, you really have to do it for everybody. And that costs a lot of money.
Thank you so much for the fascinating talk and for answering the question. You got one more question?
Given the audience here, I've got a simple question. Do you see technology replacing doctors in the future?
Sorry.
Do you see technology replacing doctors in the future?
Not me, maybe you. No, it won't replace them. It will change their model, how they work. I mean, already, you look at young doctors, they're staring at the computer more than the patient, whereas my generation stared at the patient. There wasn't a computer when I started. So technology will come, and it will change the way we do medicine. But I don't think it will replace doctors.
I can say the message I got from the Congress in Krakow was the technology will not replace the doctors, but doctors who don't use AI will just finish. So everybody will have to learn, we have to use AI in our clinical practice. That's the message I got from the Congress. Thank you very much.